hit the light. Y'all okay with the lights being off? Alright, so we're just going to hit kind of everything in a nutshell of what we've talked about this semester. So the first thing we're going to talk about is cardiac physiology, and we're going to include a little bit of the electrophysiology in there. And really it's going to be anatomy and physiology. The first thing that I wanted to talk about is the action potential stuff. Remember, you've got the phases of cardiac contractility, all right? And included in that, you also have these terms, your absolute refractory period and your relative refractory period. Y'all remember those terms? So the evolution of a the evolution of contraction in a myocardial site goes over 4 phases, okay? Phase 0. This is where you increase your voltage, all right? Remember, in order for a cell of any type to contract, to depolarize, it has to go from what to what on the inside? It's got to go from negative to positive, right? So what makes that happen? What channel makes that happen on the outside of the cell? You got your sodium-potassium pump, you've got your fast calcium channels, you've got these different proteins on the outside of a cell that allows the influx of these electrolytes to come in and to go out, and it controls them, okay? A cell, even a myocardial cell, its membrane is what? Semi-permeable. So that means that it doesn't allow for the bigger objects to come in and out, bigger solutes, all right? I like to use the example of a spaghetti strainer. It's almost like a filter, all right? If you can imagine a spaghetti strainer or colander as a cell membrane, you pour the pot with spaghetti noodles and water into that thing, all the water is going to come out of it, but all the big stuff, all the solutes are going to stay on the inside, right? Or going to stay out of the filter. So phase 0 is your rapid sodium influx. So that's what kind of gets the whole depolarization thing going. All right? Phase 1 is going to be the begin of where you have some chloride coming in and potassium is leaking out. All right? Remember, sodium and potassium have to do what? Swap roles, right? They have to reverse. The normal resting state of a cardiac cell is what? On the inside. What's its polarity? Negative, right? Relative to its outside environment, okay? On the inside of a normal resting myocardial cell, there is what? Potassium, all right? And so on the outside is going to be sodium. Phase 2 is your calcium. Calcium aids in what? Contractility, contraction, all right? So this is where you're going to start having the myocardial contraction, is when this rapid influx of calcium comes in, all right? Then phase 2 is going to be your plateau phase, all right? So we're going to have this rapid spike. We're going to start plateauing, all right? And then once contractions occurred, we're going to go back to our resting potential, right? So phase 3 is where we're going to start having what coming back in and what going back out. Sodium starting to go back out and potassium starting to come back in. And then at phase 4 is going to be your resting potential, okay? And that's just the evolution of a cardiac contraction. Now this occurs a lot, right? It occurs a lot. So your cardiac conductive system. I know this is a review. Our basic anatomy. The main pacemaker is what? The SA node. What's your intrinsic firing rate of your SA node? Okay? Then you've got your internodal pathways. They do what? They serve as a what? As a power line, as a conductor for that generated electricity that the SA node has generated. That conduction has to make it through the heart to provide for contraction, right? Remember, you've got a pairing of the mechanical activity and the electrical activity. All right? That's why you can have a patient that's in a PEA rhythm. They can have a total mismatch. You can have electrical activity occurring, but then you could have no mechanical activity. All right? So something's got to make the heart receive this electrical impulse. And so that's what the internodal atrial pathways do. Now, when the SA node fires, does it just hit the right atrium or does it hit both? It hits both. All right, so it fires and then it follows the internodal pathways along here and along here. All right. Then we go to our AV node, right? What's the intrinsic firing rate of your AV node? All right, 40 to 60. So it can actually serve as a backup pacemaker, right? Now, what is important to remember about the AV node as far as conducting this current through the heart? What does it do when that current hits the AV node? It delays it slightly. Why? Yeah, to allow for ventricular filling. All right, so the atria contracts, it pumps, but then there's still about 30% of that blood that hasn't quite made it down to the ventricle yet. So there's this last ditch part to get the rest of the blood into the ventricle. And that's called the atrial kick. Did you say a donkey punch? Oh, donkey kick. Then you got the bundle of his, all right, which again is just a big collection of neuro bundles or electrical bundles. Nerves, all right. Then your left and right bundle branches. Your right and your left. So just looking at this, kind of getting the cart ahead of the horse, if you will, and you will. Your bundle branch blocks, they occur where? In your bundle branches, right? So this is why if you have like a right-sided bundle branch, you can actually have those bunny ears because you're actually seeing two ventricular contractions at once, okay? So let's just say that I've got a bundle branch block in this bundle branch. What is going to happen to that electricity? So it's going to block it, it's going to stall out, but then there's going to be another route, right? It's going to figure out a way to make it re-enter back into the electrical circulation. But that's going to delay it. So I've got a sharp left ventricular contraction, but I've got a delayed right ventricular contraction. All right? So when I'm looking at a bundle branch block, I'm looking at my lead one. My left, I'm looking in V1. This would be my left, and then this would be my right. All right, that's why you've got bunny ears. That's why those show as bunny ears sometimes, because you're looking at two ventricular complexes at once. Does that make sense? Then your Purkinje fibers, and they are what takes the rest of the electrical circulation to the rest of the ventricles, right? So, looking at your electrical cardiogram, remember your standard limb leads. Your standard limb leads are going to be what? Leads 1, 2, and 3, and leads A, B, R, AVL, and AVF. So your first 6 leads that you look at on a 12 lead is going to be your limb leads. Leads 1, 2, and 3 form what? Einthoven's triangle. All right. where is the positive electrode in lead 2? Your left leg. So lead 2, if we're kind of looking at the normal electrical pathway of the heart, that's why lead 2 can identify lethal rhythms quickly. And that's why it's kind of our normal monitoring, because it's kind of taking a look kind of at the way that the heart transmits its electrical activity. Where would the negative be? On the right arm, right? Because we're looking from here to here. Think of your SA nodes right here, and we're just following that, okay? Now, your lead 1 is going to start in your right arm, and it's going to go to your left arm. Then your lead 3, your negative is going to be in your left arm, and your positive is going to be in your left leg. All right? These leads are called limb leads, but they're also called what type of polar leads? Bipolar. Bipolar. Because it physically takes 2 leads, all right, to get this reading. Now, I didn't put up a thing. I did not really want to get into the whole axis thing and all that again today. But you've got your standard limb leads, and then you've got your precordial or your chest leads, and they're the what through what? V1 through 6. And we're going to talk about that in just a little bit, in just a few minutes. Now, why are your precordial leads called unipolar leads?
Because they don't change the polarity. They stay positive.
Okay? It goes a little bit more with the way that you're actually getting this transmission. Okay? So when we get a bipolar lead, we are physically placing 2 leads on. Alright? With our chest leads, to get those leads, we're only physically placing 1 lead on. Alright? But they're all going to that center. They're all going looking at that same place. Alright? So they're all feeding off of the same point of access, the same negative, the same positive. Okay? Alright? When you look, well, I'll wait before we get to that because I've got that in the 12 lead stuff. Alright? Let's just, so when I do a bipolar lead, alright, I'm actually physically putting 2 leads on, alright? So when I do a V1, 2, 3, 4, 5, 6, when I do a chest lead, I'm only physically putting 1 lead on. And so they're all viewing from the same center of the heart. Okay? Does that make sense? So that's what makes it unipolar. Because we're only physically putting 1 lead on. Okay. So, talking about your ECG paper and your ECG monitoring. What does ECG monitoring not tell you? Mechanical function of the heart. It is just telling you electrical function of the heart, right? How would you in the field kind of get a baseline of mechanical function of the heart? Is that correct? We're going to look at blood pressure and pulse. And then we're also going to kind of look at hemodynamic status. We're going to look at their skin color and temp. We're going to look at their signs of hypoperfusion and things like that. Alright? So, basically a single lead, a lead 2 is going to tell you is it regular, what the rate of it is, and time it takes to conduct an impulse. Alright? Under normal circumstances, we're going to have our numbers, right? Our PRI interval, all right, up to 0.2. Our QRS up to what? 0.12, right? Then we're going to look at our QT interval and all that stuff. We start having delays in impulses when we start getting into what? AV blocks. Single lead. Lead 2, all right, unless it's right there in the inferior section of the heart, is not going to tell me if there is an infarct or injury on the lateral portion of the left ventricle, right? It's going to just show me the picture that it's taking from the area that it's taking it from, right? It can identify axis deviation. Just from what y'all remember of axis deviation, what do you need to have to identify axis deviation? You've got to have at least what? You've got to at least be able to compare two opposing areas of the heart. All right. Well, let's talk about that after a while. Because let's just move forward with that, and then we'll get into axis deviation. All right. I'd rather let's stay on something that we're all kind of keen on. It doesn't identify right to left differences in cardiac conduction. Again, it just looks at that same area, and it can't really tell you the presence of conducting action. Your paper. One small box equals what? One large box with 5 in it equals what? 0.20. All right. The horizontal axis indicates what? Okay, the isoelectric line, it indicates, when we're looking at graph paper, time. All right. It's a chronological recording. All right. And then the vertical axis indicates what? Millivolts, amperage, the strength of the conduction. All right? Make sense? Your ECG components. Basic, basic, basic. Your P wave indicates what? Atrial depolarization. Your QRS. And then your T wave. Why can't you see atrial repolarization? Right. It's not that the atria just doesn't repolarize. It's just that the amplitude or the voltage that it emits is a lot weaker than a QRS complex. So the QRS complex is going to cover it up. Your time intervals, your PRI, 0.12 to 0.20. All right? Anything above 0.20 is going to indicate some type of block or some type of atrial anomaly, right? Your QRS should be what? Yeah, 0.08 to 0.12. All right? Generally, if we start looking at something that's above 0.12, we're calling it what? A what complex? A wide complex. And then you've got your QT intervals and all that too. All right? Your general rules. The most important thing with anything, especially when we're relying very heavily on cardiac monitoring, is to do what? Treat the patient, not the monitor. Treat the patient, not the monitor. All right? Your monitor is just an aid to guide you in your treatment plan of your patient. Read every strip from left to right. I don't know how they read it in China, but here we read it from left to right. Because I think folks in China read books from right to left. Is that right? I don't know. Maybe I made that up completely.
Can't read Chinese,
I have a vivid imagination, guys. You need to apply the 5-step systematic approach. Avoid shortcuts and assumptions. And I will say this. You guys probably are more proficient now. I know you are more proficient now in identifying these rhythms than when you first started. So, when we say avoid shortcuts and assumptions, you know, if it looks like a duck, quacks like a duck, walks like a duck, it's probably a duck, right? But sometimes those cases where you just print something off and it just doesn't quite match what the patient would look like. Or that patient didn't display something on the monitor that you just knew they were going to display, right? So that's very good to try to go through that. And then even those times, you may not be able to really interpret it, and you just got to go with treating your patient, okay? There's been several instances where either myself or my partner, we've actually taken the EKG strip to the doctor, and y'all may have had medics, or y'all may have done it too, and said, hey, what do you think this is? And, you know, it could be just something as simple as a sinus rhythm with artifact, or it could be something that's way on out there, right? Nonetheless, treat the patient, not the monitor. But when you're interpreting, at least go through your rules before you get super proficient in it. And sometimes even being super proficient in it and just barely glancing at a monitor, not printing out a strip, I'll never, unless I'm working a cardiac arrest where I can just tell, I'll never hook a monitor up and not print a strip out, all right? Because it's a lot easier to look at that static strip than it is to just keep seeing these changes on the monitor. Okay? Does that make sense? It just kind of goes back to everything that I just said. So your 5-step approach, your heart rate, your heart rhythm, your P-wave, your PRI, and your QRS complex. All right? I'm reviewing these because you're going to have 6 strips that you're going to have to physically do next week on paper, and you've got to remember these steps. Your heart rate determination, there was 2 methods. Do y'all remember them? 2 methods that we kind of talked about. Yeah, you've got your 6-second strip. You can look at your R to R, or you can just count R waves in a 6-second strip. All right. The 6-second method denotes a 6-second interval. We look at all of our strips in a 6-second interval. You know where they're marked. You count the number of QRS complexes, multiply by 10. That's going to be the quickest way. All right. That may not be the most accurate way, but for probably 80% of your patients that you would need to do this on, which hardly, with technology now, you really wouldn't have to do it a whole lot. You're probably going to do that. All right. So this is a 6-second strip. I've got 8 complexes, 8 QRS complexes. It's going to be what? Now let's just say that this was a 6-second strip, but we're in 3rd-degree heart block where we've got a regular atrial interval and we've got a regular ventricular interval, but we don't have a match of the atria and the ventricle. What do we do then? Yeah, we just count our atrial rate and we count our ventricular rate. All right, your R to R method is just look at, you find your QRS complex that falls on a heavy line, count the number of large boxes between it and the next one, then divide by 300. And that's usually going to give you a more accurate view. Okay? So, let's just say this one falls the closest. So I've got 1, 2, 3. So I've got about 3.75. I've got about 3 1/4 big boxes between the two. So 300 divided by 3.75 would be what? What would 300 divided by 3 be? 100. All right. So probably we're looking at around 90 something. 1, 2, 3, 4, 5, 6, 7, 8. 80 would be the 6-second way. All right. The R to R is going to give you a little bit more of an accurate thing. All right.
That's a big difference. 80 and 90 something.
Yeah, I mean,
What's the heart rate?
it is. Did you divide by 3.75? Yeah, so if you did it that way. I mean, but still, in the grand scheme of things, how big of a difference is 80 to 90? I guess it could be, if depending on your patient condition and where they normally live. All right, so your heart rhythm. When we're looking at heart rhythm, we're just looking to identify, is it what or what? Regular or irregular, all right? with your irregular pattern, you can have a regular irregular pattern, all right? Or you could have a irregularly irregular pattern. You know, your regular irregular pattern can also be called predictably irregular. I've got Bigimini PVCs, all right? I know that I've got one PVC for every complex, right? So that is an irregular pattern, but it's predictable. I know that there's going to be a PVC after the next one, okay? What is your main irregularly irregular or non-predictable irregular rhythm? AFib, because you just don't know what it's going to do, all right? And so identifying AFib is also going to help you understand why you can't really get a good rhythm or a good rate on your monitor either, all right? Because if y'all have ever seen anybody that's in tried and true AFib, it goes from 60 to 70 to 90 to 120 to 80. It doesn't stay regular. All right, looking at our waves, we just really talked about that. We're going to look at our PRI, which is going to be the onset of the atrial contraction to the onset of the ventricular contraction. So we're going to look at the start of the P to the Q, right? To the start of the Q. Our QRS complex, ventricular depolarization, your Q wave is your first negative or downward deflection of the large complex. Now, one thing that we learned from 12 lead, if we've got a Q wave that is at least 1/3 of the depth of the R wave, but it is going downwards, what does that mean? That we've possibly got some type of AMI going on, okay? Remember, a Q wave MI? Your R wave is going to be your first upward, and then your S wave is a sharp negative or downward deflection. Your ST segment, where do we identify the ST segment? All right, so it begins at the end of the QRS and ends with the onset of the T wave. Okay? It's the point at which the QRS complex meets the ST segment is the J point, all right? So when we're actually looking for ST elevation or ST depression, we're looking from here all the way to here, all right? You'll see it? So that's where your fireman hat may come in, or your tombstone, or you may have deep depression, things like that. Your T wave, ventricular repolarization. U wave, most often not seen. Usually appears much smaller than the T wave, rounded upright, or a positive deflection if they're present. So it's going to be in between the T wave and the P wave. All right, but it's going to be a very small upright. So it's going to be, if you had a all right, so let's just say that's the end of the T wave. So you're going to have very small. I can't draw a good round upright. You're going to have a very small, and then you would start with your P wave again. So that would be your U wave. Does that make sense? And then artifact. Artifact can occur from vehicle moving, the 60 cycle interference, faulty EKG apparatus. You've got to make sure that you can get a good 12 lead before you transmit, because you do not want to transmit a 12 lead that has a ton of artifact, because that doctor's just going to throw it out, all right, because they can't really get any good information off of it, all right. Let's take about a 5-minute break. I've got 9:40 on my phone. Let's just, y'all want 5 or 10 minutes? All right, I've got 9:40 on my phone. 9:50, be back. All right, so for these following case studies, I've incorporated the management aspect. The paper that you've got, There's 5 case studies. So the strip correlates with the strip that's in the case study. So, for the following scenarios, we will identify the strip, discuss the cardiac assessment, and discuss the treatment of each patient. Case 1. Your patient is a 65-year-old female. Sudden onset of shortness of breath and fluttering in the chest. Anybody else need one of these? Her initial assessment, she's alert and in mild respiratory distress, and her airway's clear. There you go. Her history, the patient was vacuuming the house when she suddenly became a SOB. Ha 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 ha. She became short of breath. Her past medical history, she denies a history of heart disease, and she reports periods of palpitations in the past. What's her next steps? At this point, we've got this information. What's our next steps regarding management? What do we need? What do we need to do? Okay? Alright, so we've kind of made it to our primary assessment. We need to go in and get our baselines, start looking at secondary stuff. So her respirations are 20, blood pressure is 110/90. SpO2 is 93% on room air. This is her monitor. So, using your paper on here, y'all interpret this strip. Okay. So our rate,
160.
alright, somewhere around there. Rhythm,
Regular.
P-wave, kind of hard to see, ain't it?
You can make one.
Okay. QRS complex, okay. So about 160 regular, P-wave is not discernible, PRI is not really discernible, QRS complex is a narrow complex. So what are we calling it?
I would call it sinus tag, but
Okay.
you're not describing sinus tag right there.
For the purpose of this, we're going to call this SVT. All right.
Well, let me
See, the standards on SVT have jumped around and changed. It used to be 180, then it was anything above 150, and then it's back to 180. Your bottom line is there's no magical number that's going to make it just say it's SVT, because you could have a patient that, if we're going by 180, you could have a patient with a rate of 170 and be symptomatic and need treatment. Our treatment's still going to be the same, all right? It's a narrow complex tachycardia, all right? So even at 160, if she's symptomatic or she has issues, then we are going to consider using that tachycardic algorithm. Does that make sense?
You're looking at case 1, right?
Yes.
It's more than 6.
It's more than 6.
It's more than a 6.
Yeah, you got to look at your two thick lines. All right, so let's just look at it through the algorithm. Stable or unstable? Or she's stable, right? Hemodynamically, she's stable. So we're going to use the AHA adult tachycardia with a pulse. Hemodynamically stable, narrow complex, regular rhythm. If we're going to go ahead and treat it with the tachycardic algorithm, What's our next treatment?
What else? I mean, yeah.
Everything's right. Everything's right. All right. If we're going by the algorithm, let's go ahead and throw some oxygen on her. She's 93% anyways, right? But she's stable. All right. Narrow complex, stable. What are we going to do? Following the algorithm. Is it causing hypotension, altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure? No, it's not. Is the QRS wide or greater than or equal to 0.2? No. All right. So start IVs. Our next step is going to be vagal maneuvers. All right. If vagal maneuvers, I would probably think vagal maneuvers might work with this lady, especially if we've got a lower end of the spectrum heart rate with a tachycardia. If not, we're going to go ahead and throw what on? Adenosine. What's our dosage? 6 and 12. All right. If adenosine doesn't work, then we may consider a beta blocker or calcium channel blocker. Now this is the blanket AHA algorithm, all right? So it's not necessarily saying we're going to take Lee County, Alabama's protocols or Alabama's protocols and throw it in. We're saying this is what a AHA recommends for treatment for these patients, okay? So then we might throw on that beta blocker. What was the beta blocker it recommended given? Sotalol. What are other examples of beta blockers? What? Metoprolol, atenolol, Lopressor, things like that. All right? All right. Any questions about that first case? All right. Case 2. 58-year-old male found down, undetermined time down. CPR was started by a first responder. You have them stop CPR and feel no pulse. I love these. If y'all hadn't noticed, I love doing these. Your initial rhythm when you arrived, this is what's on the monitor, but what are we interpreting as? You reconfirm that the patient does not have a pulse with this rhythm. All right? So I didn't really go through the whole 5-step process with this because it wasn't going to matter here nor there for us because this patient's in what? PEA. All right? So what's your initial assessment and treatment? You've already kind of did your initial assessment.
CPR.
All right?
What algorithm was that for?
The PEA, the pulseless arrest, PEA. All right. History reveals that the patient is a chronic alcoholic. History reveals that he has been sick for the last few days. He has stopped. He has been vomiting blood and has black tarry stool. His abdomen is distended and rigid. What treatment would you consider? You got just about every one of the H's and T's in this scenario, don't you? So initially, no matter what, begin CPR, right? Without our BLS, ALS doesn't matter. We're gonna go on and throw on our monitoring pads, but is this a shockable rhythm? No, it's not. But why do we want to go ahead and have those on?
So we should convert to a shock.
Right. If we're giving all kinds of symptomatic nervous system or sympathetic nervous system stimulants, which is going to be what? Epi or vasopressin, right? Mainly epi. Then it may cause some cardiac excitation, which may throw it into VFib, VTAC, something like that. It's more than likely not going to go into any kind of real organized rhythm, but getting a little bit of electrical activity back, I'd rather go from asystole to VFib because then I can work with VFib a little bit more than I can asystole, right? So if I can at least get that heart to where it's got electrical activity started back and it's quivering and it's fibrillating and all this kind of stuff, oh, I feel a lot more jiggly after Easter doing that. Then we can at least maybe try to depolarize those cells back into a perfusable rhythm. It's not going to be a perfect rhythm, but we could probably do more with VFib. So definitely going to consider epi, start some fluids. Other treatment, y'all said it while we were talking about it, thiamine, right? You may want to go on and consider bicarb and D50 with a patient like this. You can kind of unofficially do the coma cocktail, right? You got your thiamine, you got your Narcan, you got your D50. What am I leaving out? Bicarb. All right. What is bicarb going to do? Yeah, it's going to neutralize, right? Remember, bicarbonate is your body system's natural buffer, right, for acid. Usually in a normal run-of-the-mill code, sodium bicarb is usually going to be thrown on towards the end as kind of a last-ditch effort, right? If you work a code in the hospital, the doctor's going to say, anybody think of anything else? Oh, well, don't throw bicarb on, or something like that, right? Because they're definitely in some type of acidosis because they have not been perfusing, right? What would you consider for treatment if this patient had a chest injury?
We're talking like a penetrating one. What kind of check?
I honestly can't remember where I was going with this.
Or cardiac tamponade?
Let's just move to that third question. Any changes if this patient had a bradycardic rhythm initially? A bradycardic with a pulse initially? What if it was a bradycardic without a pulse? Yeah. So yeah, if it was bradycardic with a pulse, then we'd go through the symptomatic bradycardic algorithm. If it's a bradycardia on the monitor but there's no pulse, that's PEA. We're just going to do the same thing. The whole point that I'm trying to get you to see, and I hope that you are, so don't get mad at me if you've got it figured out, is that with PEA, it doesn't matter what it shows on that monitor, all right? You can have the prettiest normal sinus rhythm you ever did see, but if that patient's laying there dead, then it doesn't matter. That doc's not going to be real impressed that you can see that P wave and look at that QRS if you bring him in a dead patient that you haven't done. Well, the monitor show normal sinus rhythm. So it doesn't matter. It could be anything. It could be a second-degree heart block. It could be, bradycardia, tachycardia. It could be whatever. All right? But if it's not a systole, VTAC, or VFib, we're going to treat it as a pulseless arrest. Okay? Does that make sense? Case 3. 68-year-old female, chief complaint, altered mental status found on the floor. Conscious, only responds to commands. She has some expressive aphasia. Given what we talked about earlier, don't shout it out, but you could already be thinking about where I'm going with this. History of present illness. Patient was found unresponsive on floor, is now awake but not communicating. Husband states that she has an irregular heart rate and takes medicine for it. What now? What do we do? Let's throw her on the monitor. Pulse irregular. Respiratory rate 32. Blood pressure 218 over 122. And this is what you see on the monitor. We kind of work through it together. What's your rate? On this one static strip, it's going to be what? About 180? Alright. What's your rhythm? Irregular. Predictable or not predictable? It's not predictable. Alright. Do y'all see why it's not predictable? I don't know when this irregularity is going to occur. It just happens all over the place. Alright? P wave. Yeah, it's very variable. Definitely in some fibrillation. PRI, kind of hard to see. QRS complex. Yeah, it's there. So what are we going to call this? AFib. I forgot to throw that in here. Oh, no, there it is. It's AFib. So what do you think is going on with this patient? We got expressive aphasia. We're kind of unresponsive or not. She altered mental status. She stroked out. Blood pressure is sky high. So we're thinking of some stroking, right? What do you think our next steps are going to be with this? This is definitely going to be a high flow diesel fuel kind of type of day, right? But let's just kind of look at our algorithms and stuff like that. We're actually probably going to be working 2 algorithms in one now. And it may not necessarily, it's an AHA algorithm, but it's not necessarily a advanced cardiac. All right? We're going to be looking at probably our tachycardic algorithm. And then we're also looking at our what algorithm? Our stroke algorithm. Okay? So we'd use our stroke protocol and all that. So there's a lot going on with this patient. So if we're tachycardic, all right? Now, this is where we're going to need guidance. All right? We think this patient's already stroked out. Yes, you can kind of look at it as what's the risk over the benefit of converting this rhythm. You got to look at hemodynamics, all that kind of stuff. Yes.
I know if they're in AFib, you don't want to convert it because they could stroke out. But if they've already stroked out, can we convert it?
That's what I'm saying. You're going to look at your risk over benefits. I would probably go on and convert it. But this is where we're going to need to call med control. This is where we're going to need to get a little direction on this. Doc, there is no doubt in my mind that this patient is stroking out. She's got a blood pressure of 200 over something. She's in AFib. She's got a history of AFib. She's got expressive aphasia. All the things are lining up with stroke. We're throwing her into the stroke center. What should we do about this AFib? If he tells you to convert it, what are you going to do? All right, so we're going to hook her up with some pads. Causing hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, yes. All right. However, this is a what? It is a narrow, irregular. So we're looking at a little bit higher dosage, right? We're still syncing to the R wave, but we're looking at a little bit higher dosage. Where if it was a regular narrow complex, we're doing what? 50 to 100, okay? Now, she's also going to need some medications as well. What medication do you think would probably work better? Would adenosine work on this situation, do you think? No, I'm not thinking so, because we're looking at a upper chamber issue. Adenosine really helps what node? The AV node. It helps with the it helps slow the conduction to the AV node. All right. So more than likely, the doctor's going to get you to probably give amiodarone. Okay. Why would what? Well, you may if you got it on your truck. But most trucks will have amiodarone. Do y'all have propanamide up in Lynette? Y'all? Well, y'all in Georgia, y'all got everything. You don't have amiodarone? I don't think GPS has amiodarone. I think I've told y'all before, when I was working in AMR, one of the first instances where I had to actually give adenosine was a lady working at the fried chicken place over off exit 13. She was just what you would expect. It's textbook what you would expect from somebody in SVT. I feel like my heart's racing away. I just feel lightheaded. Don't feel that great, but she wasn't unstable. So I call the doctor. I say, "Hey, doc," I can't remember. It was the foreign doctor that worked there. No, it started with an O, I think. Anyways, he said, I was like, hey, you want me to give some adenosine for this? He's like, you can, but if you give that adenosine and it flutters down and then goes back up, you're probably going to know that it's not a SVT and it's more of a AFib RVR. Remember me telling y'all this story? So anyways, I did. I gave that. Then I gave another dose of 12. And he said, if that doesn't work, then try amiodarone. Of course, I was at the hospital by the time that occurred. And so we get her in, and they give her amiodarone. They give her the first bolus of amiodarone, and it starts converting down. Now, she went back up, and so they ended up having to do an AMI infusion. But other medications that might work on AFib, what do you think another one is, an antidysrhythmic? Lidocaine's going to be a ventricular only. All right, cardizem may work. Cortisone is amiodarone, yeah. Starts with a D. Not dopamine. Dopamine's inotropic. It's not antidysrhythmic. All right. Diltiazem is cardizem. Starts with a D. It's a cardiac glycoside, but it also has digoxin. Digoxin is given for AFib. All right. It's also called Lunoxin as well, but it's the same drug. And then here's your stroke algorithm. The biggest thing with stroke is going to be identifying the time, all right? And the reason why I kind of threw this in here is because we have to do a lot of the same things with suspected STEMI that we do with CVA. We've got to figure out the time, and are they a candidate for what? Fibrolytics. All right? So I'm not going to get real deep with this algorithm. But another thing that you have to do if you're working in Alabama and you've got a obvious stroke or even not so obvious stroke so that you don't get in trouble is what? Call the stroke center, which is just the trauma center. All right, case 4. 70-year-old male, altered mental status weakness. You find a 70-year-old male who is confused. Family states he is weak and dizzy when he stands. Patient was watching TV, stood up, became weak and dizzy. This is continued and he is becoming more confused. Has a history of heart trouble but does not take any medications. What now? Same thing as the other two, right? Vitals. Blood pressure 90/40. Pulse should show regular. Respiratory rate is 32. Monitor is what you see there. O2 sat's about 92%. Just looking at it, what do you think? What do you see just right off? All right, so what's our rate? 40. What's our rhythm? Yep. We see a P wave? All right, what's your interpretation of the P wave? Upright, rounded, regular. Your PRI. I see about what? 0.16. And your QRS is what, about 0.12? Yeah. And it's hard to see up there. Okay? So what are we calling it? Audrey called it? Brady? Stable or unstable? Yeah, go back and think about it. Yeah, his blood pressure, he's increasingly getting worse with his mental status. Now, does that really matter just right off with our bradycardic algorithm? No, because treatment's going to be pretty much the same, right? We're going to start with what? All right? If the bradyarrhythmia is causing hypotension, it is. Altered mental status, it is. Signs of shock, chest discomfort, acute heart failure. Very first thing we're giving. All right? What's the dosage? 0.5 every what? For a total dose of Alright, if that doesn't work, we can jump on what? Alright, TCP, we can start pacing or give dopamine or epi infusions. More than likely, you're going to do dopamine because you've already got a dopamine infusion mixed up in your drug box. Okay? So this is the treatment we just talked about. You're trans-Q pacing at a rate of 70. Alright, any questions about that case? Case 5. 54-year-old male, executive of an insurance company. He is complaining of chest tightness radiating to his left arm for the last 22.5 hours. 2.5 hours. He's complaining of slight shortness of breath. No previous history, but does have a remarkable family history of cardiovascular disease. Skin is pale, cool, and moist. Blood pressure is 104/82. Pulse is 102. Respirations are 20 with good tidal volume. Pulse ox is 99%. Lungs are clear. Chest pain is getting worse. Monitor reveals what? ST elevation where?
2, 3, ABF, B3, B6. A lot of places.
Alright. So, when we're interpreting a 12 lead, let's go in our normal 5 steps, and then we're going to add our things that we need to look at with a 12 lead. Our rate. Y'all all have it on your, everybody's got this copy, right? Okay. So our rate's about 75. Alright. You can just go off your lead 2 that's down on the bottom. Our rhythm is regular, right? There's no irregularities about it. It don't look good, but there's no irregularities about it. Our P wave. Round, upright, regular. PRI is a little bit extended. QRS complex is present. That should say greater. No. It's less than. Alright. So, according to your rules, your 5 rules, it's just a sinus rhythm, right? But there's something going on, right? So looking at the individual leads, this is a lot more dramatic when it actually has the animation where it pops up and says, "That's right, aren't you so smart?" But I couldn't figure it out on present. Alright? You look at your individual leads. I mean, it just jumps out there. You can see this fire hat, right? Leads 2, 3, and AVF. So, with our 12 lead, leads 2, 3, and AVF are going to be our what? Go ahead, Sam.
Yeah, we had a question. If it's a PRI of 0.24, why is it not a first degree heart block or secondary?
Well, it is. You could say that. I didn't say normal sinus rhythm either. I just said sinus rhythm. But yeah, you're right. I mean,
It doesn't really look like 0.24 either.
what's it look like to you, Brian?
0.20.
Okay, then if it's 0.20, then it's sinus rhythm. Funny thing about big fat fingers, I don't have big fat fingers, but sometimes I hit the wrong button. Leads 2, 3, and AVF. All right. So on our EKG paper, it's the L there. What area is that? Inferior. What do you consider as a possible diagnosis? So we've got an inferior STEMI, right? So what algorithm were you going to use? I think I just heard you ask that. What algorithm would you use? Your ACS algorithm. Alright? You're going to use your STEMI algorithm. What would be your initial pre-hospital care treatment considerations? MONA, right? MONA. But it's not in MONA order. It's going to be oxygen first. Administration of 325 of aspirin. 324. Gotta get an IV. Always, always, always get an IV before you start that nitro. Okay? We're gonna give nitro. Just taking it a step back to AMT days. Your dosage of nitro.
0.4.
Alright, 0.4 per. How do you administer
Per
it?
dose.
Alright, per dose.
3 to 5 minutes.
Sublingually every 3 to 5 minutes after 3 doses.
That's all y'all had to say. Watching what?
Blood pressure.
For keeping systolic 90 or greater. Alright?
That's right.
So, obviously we're giving oxygen because he's got some cardiac infarction, right? Some ischemia going on. So we want to give that supplemental oxygen. Even though his O2 stat was very good, we still want to give him some oxygen. We want to flood him with oxygen, okay? Aspirin.
If you were suspecting an inferior MI, would you not want to give mine?
Well, that's what I was going to get to in just a second. Aspirin. Well, I'm jumping all over the place. Aspirin. What's it doing? It's just lubing up them platelets, right? It's lubing up them platelets, letting them scoot on by that clot. Why is that word such a dirty word? I mean, you go to any oil change place and it's got the word lube all around it. You don't see any guys cracking up about it.
You don't know that.
It just makes it slippery. Makes it just glide. Let's move on. Nitro. All right. So what did you say, Bo?
I said if you suspect an MI that's inferior,
We definitely need to consider
at least have a laboratory.
the administration in nitro, but we need to consider the fact that it is an inferior MI because we're looking at the bottom part of the heart, all right, and the bottom part, the right side, that area of the heart, it's going to depend on this preload, all right, and we need to get this fluid up. If we go vasodilating, we're going to decrease preload, all right? We may dump their pressure way down, all right? So you need to have what going or what ready? Fluids, definitely. All right? And then we're giving 2 to 4 milligrams of morphine. For those of you that had my static station last week, if I told you wrong, I apologize. It is 2 to 4 milligrams. I think I was telling folks 1 to 2, but it's 2 to 4. Okay? Why are we giving morphine? It's kind of a twofold drug. It's going to make them feel better, but it also helps continue to vasodilate, and it helps to take what off the heart? The workload off the heart, the oxygen demand off the heart. Okay? So funny, Giggleson. All right, so our acute coronary syndrome protocol. Do we have symptoms suggestive of ischemia or infarction? All right. Monitor ABCs. We're always going to be on the ready to treat this patient if he codes, okay? Especially with that big old tombstone, big old fire hat that we saw, and it's an inferior MI. Be ready. He's very symptomatic. All right, so your Mona stuff, your ST, if ST elevation, we need to go on to transmit, right? Some area hospitals or some hospitals have the STEMI team, right? The cath lab team. We at least need to let them know that it's coming so that the doctors can get in touch with who they need to, okay? So, moving on down on this. Now, this one has a lot of non-pre-hospital oriented stuff. Again, this is the blanket algorithm. The way the algorithms work, you're going to treat PEA, you're going to treat VFib, VTAC the same in the field as you would in the hospital. It's the same treatment for most of them. All right. For this one, there's going to be a little bit different modalities because there's different diagnostic things that they can do there, and they're also closer to the cath lab. All right. Our ECG interpretation. ST elevation or new or presumably new left bundle branch block. ST depression or dynamic T-wave inversion. Normal and non-diagnostic changes in ST segment or T-wave. Which way are we going with? Yes, we're going with the STEMI. Start adjunctive therapies, as indicated. Time of onset, very important. Very, very, very important. We get our time of onset. All right? If it's less than 12 hours, we're hitting straight to reperfusion goals. Okay? Remember we talked about the door to balloon time, all that kind of stuff? They're going to get various labs and stuff like that that I'm not real worried about for us talking about in here. This is going to be important, though, at least in Opelika. If you've got a chest pain patient, you definitely want to get a gold top tube of blood because the gold top gives you your troponin levels. Your troponins, what are troponin levels? They're cardiac enzymes that are released by the myocytes or the myocardial cells when they are injured. All right. So if you've got somebody that does have a large area of ischemia, you're expecting a person to have a relatively high troponin, and we do serial troponins in the hospital, which means we'll do one every 6 hours or something, but it's obvious that you're expecting those enzymes to continue to climb because most of the time an MI does extend a little bit, and then it continues until we start reperfusion therapy, but the heart is taking a shock, and so then it'll start going down. Relatively, in the body, you shouldn't have any troponin enzymes until you actually have an insult to heart tissue. What?
This is a little bit off subject, but if someone was in a car wreck or something and they had chest trauma, would we want to go ahead and get the gold top to see?
You would have troponins in, pericardial effusion, pericardial contusion, anything like that, anything that's going to cause insult, you would have those troponins. They're really more to help the treatment of MI and things like that. Trauma, you're going to want to get more of the stuff related to the trauma, your blood count things, stuff like that. Which that's a total different lecture altogether. Okay? Reassessment. Chest pain slightly better. If it had not gotten better, what would you have considered? Another dose of nitro, right? Maybe some more morphine. Alright. This is the last part of this little review. What time is it? Are y'all good or do y'all need a break? 10 minutes. We'll be done with this part. Alright. 12 leads, different point of view. Remember your 12 lead ECG takes your limb leads, alright, which your limb leads are what? Lead 1, 2, 3, ABR, ABL, ABF, and then it supplements them, or it adds 6 more leads, okay? So your standard 12 lead interpretation, your 6 precordial leads are going to be a view of what part of the heart? Different areas of what chamber? The left ventricle. All right? If you want to look at the right ventricle, you're going to need to take V4, place it in the same anatomical position on the right side. Okay? If you want to look more posterior, you're going to need to get a 15 or an 18 lead ECG. All right? The average direction, the cumulative direction of all electrical activity is called what in the heart? The average direction that all electrical activity is going is called the axis. The electrical axis of the heart. All right? The axis of the heart is normally going from SA to ventricle, right? So you got your lead 1. So this is lead 1. You've got your negative to your positive. The camera is where the positive is. Okay? So if you're running at me, and I'm taking a picture of you running at me, that's what this is. The electrical activity is running at the camera. And we're taking a picture of it as it's running towards the camera. Does that make sense? Alright? So lead 2. Again, lead 2 is your best just quick look for electrical monitoring because of what principle here?
It follows the pathway conduction.
Yeah, it follows the axis of normal conduction, right? It follows the SA node, AV node. I'm so proud of y'all for using that big word. Then you've got your lead 3 and your AVF, AVL, and your AVR, okay? Just a quick reminder. Just a quick reminder.
I remember last time we did something like that.
When we're looking at axis deviation, alright, we're just looking at any electrical deviation off of the normal axis, okay? So if we've got right axis deviation, that means that the normal axis is going to the right. We've got left axis deviation, it means that the electrical activity is going to the left. What would cause electrical activity, electrical current, to go more towards the left side of the heart?
Like dead cells where they can't conduct.
Okay, so you're thinking of opposite, alright? Left ventricular hypertrophy, those real thick, when the muscle gets real thick and the muscle requires more electricity to conduct, it's going to draw that axis towards it because it's going to need more electricity. Alright? When you got infarct or injury, you've got a whole bunch of myocardial cells that can't use that electrical activity, right? So it's going to go away from it. Alright? Does that make sense? That's where we're staying with that. I see all leads. Yes, I've told you a million times. I see all leads. Lead 1 is lateral. Alright? I see all leads is not really like a way to remember it in order. It's just for you to remember. I, inferior, S, septal, A, anterior, and L is lateral. You can also remember Lisa. Alright? Lateral. 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 Okay? If you think about it, kind of, when you look at your 12-lead ECG, if you think about where that lead is actually positioned, it's going to help you remember, okay? If I've got my, well, I can't draw good enough. If I think about where my 6 leads are, all right, I know that V5 and V6, they're placed way on the left side, the lateral side of the heart, right? So I can remember that V5 and V6, they're at the most lateral part of the heart. All right? Anterior. All right? So if V3 and V4, they're going to be anterior. So they're going to be more right on top of the ventricle. Okay? They're going to be more right on top of the ventricle. All right? Then V1 and V2 is going to give you a septal look. It'll give you a little bit of an anterior, but its main is septal. What are we talking about septal? Where's the septum? Yeah, the intraventricular wall, all right, between the two ventricles, all right, the intraventricular septum, okay? All right? Leads 2, 3, and AVF, they're going to give you an inferior view. All right? And it's kind of hard to relate those exactly as to how to imagine where they're looking at. But if you can remember where your anterior, septal, and lateral is, then that only leads your inferior for leads 2 and 3. Okay? Does that make sense? Thanks. ST segment elevation when we're looking at 12 lead. We're looking at least 1 millimeter above the baseline in your limb leads and at least 2 millimeters above the baseline in your chest leads. So normally your ST segment is going to be isoelectric. All right. You start having ST elevation minutes to hours. All right. Still have a T wave there. Then you start seeing a T wave inversion. Notice what I was talking about earlier. See how your Q wave right there is just about baseline? See the difference here? Does that make sense? All right. Now, months after, we've got a little bit of ST elevation here. We've got a pathological Q wave. All right. Does that necessarily mean that that they're having an active STEMI? No, it just means that that heart was what? Injured. Injured bad. And this is just a picture of an anterior septal MI. Where's your anterior? Where will we be looking for anterior? Yep. Now V1 and V2 are going to be mainly for septal, so we could even say this is anterolateral septal. This joker's heart's sick. Alright? But they're saying anterolateral. You definitely can see the ST elevation in all these. Then you've got, you look at your reciprocal leads, alright, you have some, what? ST what? Depression. Remember reciprocal? Remember the term reciprocal? Alright? We're going to look at the exact opposite area of the heart and see what that looks like. Alright? That's why when we did axis deviation, we looked at AV, what? F and lead 1. Alright? Because they are perfectly looking at different areas of the heart. Bundle branch blocks. I already talked about these just a little bit. Rabbit ears are not absolutely reliable, but you know they can aid in you determining that. All right. When you're doing a 12 lead and you're looking for a bundle branch block, what area are we looking at? What lead are we looking at? V1 is going to be your main one that you look at. V1 may look at V2, but why is V1 the area that you look at? Think about it. Think about what V1 and V2 are looking at. All right. So you're looking at the septum. All right. So V1 and V2. All right. Yeah, it makes sense. I hadn't really thought about it that deep. But you're looking at your septum. What is in the ventricular septum? Your bundle branches. All right. So that's how you can remember to look in your V1 and 2 leads for your bundle branch blocks, because of where they are looking. So your left bundle branch block, go to lead 1, V1, identify the J point. Alright, remember the J point? The point in where the S and the T hit. Which way does the QRS complex go from the J point? goes down, right? Your QRS, your J point is right here. So if we look this way, our QRS is what? Going down, right?
You're looking back
This is just a quick way to determine this. There's no like big rules into this or anything. What I'm just telling you to do. Alright, so here's my J point. I'm just looking at the QRS that preceded it. The QRS is it inverted or upright? It's inverted. Alright, so it's pointing down. Alright, when you hit a turn signal to go left, how do you hit it? You hit it down, right? So, if it's your QRS is pointing down in lead 1, in V1, it's possibly a left-sided bundle branch block, okay? You're not going to necessarily see the rabbit ears. Oh, man. I feel like somebody drew the anarchy sign on there. You're not necessarily going to see the rabbit ears, all right? That's called the turn signal approach, all right? If you look back and it's upright, which way do you hit a turn signal to go right? Up, right? Your right bundle branch does not cause ST elevation. You evaluate the ST segments as normal. Evaluate the same as a left bundle branch block. The QRS is positive from the J point V1, and you may see those R prime waves. See them right here? That's definitely rabbit ears, but you've also still got the R prime waves here. Alright, does that make sense? Why do I keep doing that? I like being able to zoom in. Alright, important stuff. We've already hit most of this. The biggest things that I wanted you guys to remember when we're talking about cardiac management. Our first thing that we look at, yes, I will allow it. Is it too fast, too slow, or is it moving at all? We're not just talking about the electrical output or the electrical rhythm on the monitor. We're talking about the myocardial muscle, right? The myocardial tissue. If it's a normal rate, then what other factor is affecting cardiac output? It all boils down to we've got to get cardiac output fixed. If it's too fast, it's affecting cardiac output. If it's too slow, it's affecting cardiac output. Cardiac arrest, no cardiac output. Everything goes back to cellular oxygenation. The very basis of life goes back to cellular oxygenation. The role of the heart is getting those cells the nutrients that it needs by the blood. So what is affecting the heart's ability to pump the blood to the cells? What do we need to do to fix it? All right? It's going to either affect stroke volume or heart rate or both. Okay? So we need to figure out what do we need to do to fix heart rate, what do we need to do to fix stroke volume. Are too slow. We've talked about it, atropine, dopamine, epi, your trans-Q pacing, and then transvenous pacing. Are too fast. Stable or unstable. Alright? What part of the cardiac output formula is too fast affecting? Stroke volume and heart rate, right? Those affecting both. So we need to figure out a way to get them both under control. Alright? How does it affect stroke volume? How do your tachycardias affect stroke volume? Yeah, it doesn't allow for ventricular filling. It doesn't allow for old Frank Starling to do what he needs to do, right? And then, of course, your heart rate is too fast, so we need to get it slowed down. All right? I thought that 12 lead was the last part of it. We're getting close to the end. Do y'all need a break, or can we finish up? Okay.
It's just a game we play in our mind.
It's a joy being me. So your strips that fall under that is your AFib, your A-flutters, your SVTs, and your VTACs. Your treatment. If they're stable, we're doing what? Vagal and then medications, right? If they're unstable, immediately cardiovertin, right? So your stable, narrow QRS complex, vagal, adenosine, beta blocker, calcium channel blocker. Get an expert. You're going to be experts. Your stable wide, adenosine and antiarrhythmic infusion. They're probably going to want you to just jump onto your antiarrhythmic infusions. All right. Your dosages of all these, we've already talked about these. Any questions about your tachycardic medication dosages? Y'all zoned out because we still got another thing to do. VTAC and VFib, medications for it, epi, vasopressin, lidocaine. All right. What other meds? What other meds in your VTAC, VFib? Amiodarone. All right. High quality CPR is what's going to save somebody in PEA or systole. None of your drugs, none of your shocking. CPR is what's going to save them. And save them too. All right. Return to spontaneous circulation. What's the most important thing to remember about return to spontaneous circulation? Continue CPR if you get a pulse and rhythm back for the first 2 minutes because of the fact that they are probably in cardiogenic shock, right? The pump's not working. Let's get the pump back working. What types of medications are they probably going to need? One, to keep them from going back into that arrhythmia, right? And then two, what? Dopamine, some type of inotropic agent, right? To help them get a little bit more stroke volume. Probably to help with their heart rate as well. Now, what are some important questions to ask with return to spontaneous circulation as regards to what you're going to report off to the hospital and maybe even some treatment that you're going to begin in the field? Was it witnessed? All right. Was CPR immediately started? How long downtime was? Was it a VFib, VTAC rhythm that was shocked? All right. If the answer is yes to these questions, in a short downtime, witness, what are we going to do? Start initiating hypothermic protocol. All right. You need to have these questions answered. All right. Because when you give your report, they're going to need to get stuff set up. They're going to need to get in touch with a cardiologist, and they're going to need to get them to cath lab. They're going to need them to get cooled down. What are we going to do to start cooling them down? Ice packing them. Ice packing them. They be packing, y'all. All right. Any questions about that? All righty.